I'm actually at a conference, a digital health conference in Excel in London. So I hope there's not too much background noise. And directly after this, I'm on a panel talking about the Equity Charter. So it's we have a stand on the Equity Charter as well. So it's a day of Equity Charter for me. Let me just share my screen and hopefully I can do this without too much bother. Just bear with me 2 seconds. Should just be, let me just get to where I need to be. Can you see the Equity Charter slide? Yeah, great. Okay. So yeah, I'd like to just spend 10 or 15 minutes talking about the Equity Charter, how it came about, who's behind it, where we are now, and what our plans are. But just briefly a little bit about me. So I started life training as a social worker, always been interested in human factors and the people side of things. And yeah, trained as a social worker, then spent 25 plus years in the NHS in various strategy and innovation type roles. It was my PhD that got me into digital, which was an online ethnography in the mental health field. And then I ran a digital health consultancy, mostly focusing on mental health for a number of years, had a spell in a startup, ran my own consultancy, and now I'm Director for Digital Data and AI at Kent, Surrey, Sussex Health Innovation Network. And myself and my two colleagues, Aisha and, let me just go back, I'll show you a picture of them in a minute, Aisha and Hassan founded the Equity Charter around 18 months ago. And I'll just take you back to, in fact, there's probably a date on the Guardian article, but it was around 18 months ago. It was the night before Rewired, which is a big digital health conference that takes place each year in Birmingham. And the owner of a big software company in the NHS, TPP, you can see a picture of him there, was reported in The Guardian as saying some very racist and misogynistic things about the MP, Diane Abbott. He was actually exhibiting at the show. He had to take down his stand, or the stand was taken down, and he was told he could no longer exhibit at the show. And Aisha, Hassan and I were so appalled by the comments that we heard in the reports in The Guardian, but also the fact that actually everyone had known for a long time that there were issues and nothing had really been done, that we decided to take a stand. So we wrote an open letter and we got lots of 1,000+ signatories in a very short space of time. So we decided to bring EDI experts and digital health people together to think about how we could nudge and shift the dial on equity. And our observation was that really equity wasn't being talked about greatly, as far as we could see, in spaces like digital health conferences. So we brought around 30 or 40 people together, and out of that we created a charter. And you know, charters are 10 a penny really, but it was a set of principles, and we've done work around those principles. They're almost like a boundary object against which we could advocate for greater equity within our sector. So that's me pulling a very smug face. I need to change that photograph. But yes, that's me. That's Aisha, who's a consultant psychiatrist and a CCIO in an NHS trust, and Hassan, who does all sorts of work. Many of you may know him. He's very prolific in the digital health sector. But it was the three of us that came together to create the Equity Charter. And I guess just a little pause here, and maybe this is something that everyone knows, but I just thought it's worth doing a little bit about, okay, what is equity, and particularly what is equity as distinct from equality. So equity is about treating people fairly and justly according to circumstances, and that might be positive action, it might be removing barriers, recognizing that people have different starting points. So we actively and intentionally use the word equity rather than equality, which is around giving people the same resources. So we wanted to think about the different assets, the different resources, the different starting points that people within our community and those who are underserved by digital health products and services might face. So our purpose is very simple. It's to advocate for equity in digital health with a particular focus on standing up to racism. But of course, we do recognise that we lead intersectional lives, and it's really just because that's where the energy came from. So that's where we've decided to focus. And, you know, we're always looking to build alliances and coalitions with others. And our vision is for a more equitable digital health sector. And ultimately, this is always going to be about, when you're thinking about the NHS and healthcare, it's always going to be about experience and outcomes for people on the receiving end of healthcare services. And really, we want to make sure that everyone's needs are met, particularly those who are traditionally and often underserved. And listen, here are just some examples of inequity in the design of products and services. So many will be familiar about pulse oximeters not reading darker skin tones. That became apparent during COVID, about AI-based technologies amplifying bias, and about genomic studies based on data from white subjects. There are just many and varied, and you no doubt between you will have loads more examples than me. I mean, the other thing I just want to note is that in the 18 months since we set up the Equity Charter, the UK and the global context has changed quite significantly, and not for the good, I would say. So in a way, it feels more difficult to do this now, but ever more important, which sort of makes us even more determined to carry on with this work. So yes, so there's a strategic case around sort of health improvement. There's a business case around sustainable organisations, and there's also a sort of a moral case as well. So there are many different ways in which we're trying to think about this topic. And there are multiple opportunities to design, and I specialise in design thinking, and I would say that we've too often designed out equity, but by the same token, we can design in equity into different aspects of the digital health sector. So we have a core set of principles, and for each principle, we have suggested actions. We're not the equity police. This isn't a top-down kite mark type approach. This is much more of a social movement, nudging approach. So we've suggested actions that people can take. Here are our principles. The most important, actually, is the individual one, which is each of us committing to standing up for equity. And that's, I guess, the difference between being non-racist and being anti-racist, for example. We've got a principle around leadership, around policy and practice, all the way through to thinking more broadly about health and well-being outcomes for underserved communities. So those are our principles that we co-designed. And as I say, each of them on our website has suggested actions, and we're constantly reviewing and updating them. So this is a voluntary thing. We're trying to work with the power of attraction rather than the power of compulsion. And we really recognise that this is not a transactional thing. This is this is trying to interrupt deeply embedded institutional norms and practices. So, senior commitment's really important, and each of us individually and as groups, as teams, as organisations, thinking about what steps we can take to shift the dial to nudge the sector forward. So I'm just going to tell you, I've got some things there that you could potentially do, but I also just want to tell you a bit about what we're doing. So we are 3 volunteers. We don't have any funding as yet. We're always trying to get some, but it's not not necessarily that easy. Although we do have a small resource now, and we're hosted by Health Innovation Kent, Surrey, Sussex. They've been a fantastic support to us. We have some amazing volunteers. So, for example, we have a marketing expert from a digital health company who gives us 1 day a month, supporting us with our marketing. And we're about to launch a community of practice. And I'll send the link, actually, when I get off this, I'll put the link in the chat, Sabine, or I'll send it to you to send round to people. We're launching a community of practice that we're launching on the 10th of November in London. It's going to be mostly online, but the first one is in London. And we've got Gurnak, who's a GP, and Emily, who's a nurse, who are going to run that community of practice on behalf of the Equity Charter. We've also just developed a half-day diagnostic for digital teams, either in the NHS or in the commercial sector to have a think about where they sit in relation to the principles and how they might nudge the dial themselves. And then we can tap them into deeper resources, but we're really excited to get going with that. And we're also looking for case studies as well. So if any of you are doing work in this space, please do share it with us. We send regular emails out to our supporters, and we're always keen to highlight good practice. I've just been on our stand talking to a person who has a dentistry startup, and he's got an AI algorithm, and they're training the algorithm on the mouths and teeth of underserved communities, starting with South Asian people, in order to support people from communities that may get less access to or use dentistry less often. So there's all sorts of interesting innovation going on out there, and we're super keen to hear about it. But we would love it if you would consider signing up to support the Equity Charter, either as an individual or as an organisation, to maybe thinking about how you could apply it in your organisation. You might want to assign someone who has a responsibility to think about equity, think about an internal audit. That sounds very formal. And we have got our diagnostic, but it doesn't have to be. And then share your case studies, get involved, come to conferences like this and come and speak to us. We get a lot of energy just from the conversations that we have. So listen, Sabine, I hope that's okay as like an introduction. We'd love to hear people's thoughts, people's comments, and have a bit of a conversation if that's good for everyone.
That's perfect. That's perfect. So people can raise their hands or put a question in the chat. I'm also going to stick a link to the Equity Charter in the chat so people can have a look at your website. And if you can find the link to the community of practice, that might be quite a good thing to put in there as well.
Absolutely do that now. If you just bear with me, I'm just going to find it while we chat.
So I'll let you find that first before because I have a question.
Yes, I'm going to do it. Excellent. I would love if anyone's got any examples of work that they're doing. And Mahima and I have done some stuff together as well. I was over in Melbourne, gosh, about a year ago. In fact, it's around this time last year, actually. And we did a one-day workshop on digital equity within mental health. So yeah, I'm just posting it now.
Okay, perfect. So tell us a little bit more about the community of practice, if you can. So what are type of activities the community is planning to do, and what you're hoping to get out of that?
Yeah. So the community of practice is really for people who, there's lots of people who just want to sign up, be a supporter, get information and be connected to the conversation. But there are also people who maybe want to take a little bit more action, want to think about what they can do in their context. And so the community of practice is for people who want to take a little bit more of an active role and want to join a community where they can share learning, come together, maybe access resources, share experiences, and get a little bit of energy, because it's an easy work actually. So get a bit of energy from each other as well. So that's the purpose. Emily and Gunnar are going to create a Teams channel for it, so there can be some connection online. Probably have 3 online sessions a year, and then maybe 1 face-to-face a year as well, because it's really nice to get people together. You sort of can't beat getting people together in person, can you? But when you're trying to build a coalition nationally, then that's a little bit tricky.
Yeah. And I think one of the things, and we'll bring that up when we talk about the strategic intent that's more focused on academia, but has a very similar purpose to your Equity Charter, is the implementation side. So it's great that you've got these actions to help people translate these high-level principles into concrete things that people can do and organizations can do. So tell us a little bit about the main, sort of organizational commitment can mean many things, and in the end, people. So we've talked to our strategic management, the strategic leadership team, and their question is, what does it cost, for example, right? So commitment is, what does it cost? Yeah, is there money attached to this community? So are there different types of commitment in that sense? So what have you learned from from implementing
That's a
it?
really interesting question. We did have a lot of people tried to push us towards taking what we felt was maybe a little bit more of a transactional approach, which was more of a top-down compliance type approach.
Mm-hmm.
And we just felt that our theory of change, we wanted our theory of change to be more about social movements, which is more about ground up, grassroots. And it all starts with individuals and people coming together as in coalitions or alliances. So in a way, the set of principles and the suggested actions of what an organisation who embraces this principle might look like, the sorts of things they might have committed to, is really a way of giving a frame for people to think about how they apply it in their context. So, you know, and I think when people are asking about the cost of doing it, I would also ask about what's the cost of not doing it. So we often don't think about the cost of not doing something. And if we have an inequitable workforce, a workforce that doesn't embrace diversity and inclusion, we might get less retention, we might get higher turnover, we might not recruit diverse staff that help us think from multiple perspectives about the work that we're doing. So I would argue, you know, these things are a little bit intangible, but I would argue that there's a cost to not engaging with equity. And as I sort of said, I think in the middle of my presentation, it's never been more important than it is now, because it is really against the grain in a way that I would never have imagined it could be.
Yeah, no, I fully agree with that. It's hard, but all the more necessary. And
100%.
before I let you go, I wondered, Mahima, I don't want to put you on the spot, but you've been working with Victoria for a while now. So I do wonder, also give us a bit of a bridge to your talk and to Laura's talk. How do you see the relationship with the work that you've been doing with the strategic intent and the work that Victoria's been doing? Because I think the intention of both things is very similar.
Yeah, that's great. From what I understand, I think they were sort of created with two slightly different contexts in mind. So Victoria, you were saying yours was around potentially even more industry focused, ours was more around the academic research focused. So some of our strategic intent principles, which people will see in a minute, will capture things more specifically like research methods or how we engage with consumers in research and university leadership and governance structures. Having said that, I think there is a lot of overlap as well. So just eyeballing the principles, Victoria, that you were showing before, it does seem like there's opportunity there to kind of like exchange notes a bit and sort of think about if there's ways we can enrich each other's work and sort of how to kind of even partner in a bit more strategic manner to really raise the tide across the entire sector, whether it's industry, academia, civil society organizations, and so on.
And just if I could come in on that, I absolutely agree, Mahima. And it's a lovely, happy coincidence that we were both working on something around the same time that's with a slightly different emphasis or focus, but a lot of mutual sort of overlap as well. And one of the things I didn't mention was for each of our principles, we've identified a partner. We realised that we don't have the capability or the capacity to work on each of the principles, but our partners do. So so we have got one principle which is around research and innovation, and we would love to think about how we partner with you on that one. And I think for anyone interested in research and innovation, then they go to your set of principles, which are much deeply more focused on research. So I just think there's a really nice relationship. And also people might come at this from lots of different angles, either like practically from a website sort of point of view or from conferences. And then we can help people find the space that feels most comfortable and relevant to them. But, you know, this is all about networks and relationships, isn't it? So the more we can create energy in this space for equity, the bigger impact we'll have. So I absolutely agree, Mahima, and really keen to collaborate and collaborate sort of across continents as well, because you know you're doing such interesting work in Melbourne, Mahima, and it's always good to have you over in the you in the UK at the moment.
I am.
Good to have you in the UK at the moment. Yeah.
Thank you. Amazing.
Yeah.
Very promising.
Very promising. And Victoria, we are going to collaborate if we ever can find a slot in our diaries that we're all free.
We will do it. We will do it.
We'll persevere. I'm going to let you go. Have fun and at the conference, and good luck with the panel. And thanks so much for coming today.
Thank you. I'm sorry I have to leave. If I could
Don't
have the
worry.
recording, I'd love to hear it. But thank you so much, and I hope you enjoy the rest of the session, everyone.
Thank you, Victoria.
Bye. Bye.
Bye. Mahima, I'm going to hand over to you now for your bit. So Laura has arrived. So I've no idea if she can speak, but we'll see. We'll play it by ear.
No worries at all. I'm just going to put this on presenter mode. Bear with me a second. Can you see this properly? Okay. Amazing. So thank you, everyone. I will apologize for my croaky voice in advance. I was very convinced that I had allergies, but it turns out I do have a cold. So sorry about that. It was lovely to hear about Victoria's work, and you might find there's a little bit of overlap in the work we are presenting now, but very keen to hear everyone's thoughts. And as I'll mention in a bit as well, we do have about 30 minutes at the end to hang on for a bit longer and have a deeper discussion. So we do welcome and encourage you to stay for that. But without further ado, I guess we can dive in. So my name's Mahima. I'm a research fellow at the University of Melbourne. I work at a digital health studio called the Validitron. And we've been lucky to host Laura and Sabine over there as well early this year. And so this is very much a joint collaboration between Manchester, Melbourne, and Toronto. And I will say, looking at the participants list, our Toronto counterpart Ibukun is on the chat as well. So that's fantastic. And I do see some familiar names from my trip last year at Manchester, which is really lovely to see this continuity. So, as I was saying, I'm the Melbourne lead for the International Collaborative for Translational Digital Health. I will talk about that in a minute and just give you a bit more information about what that actually is. But as I was saying, I'm a research fellow at a digital health studio called the Validitron. I have a background in engineering and management consulting, so I worked in industry for about 10 years before becoming a full-time academic. At the Validitron, I focus on co-design of digital health solutions. So my role is very much focused on being a bridge between industry, health services, and consumer partners, as well as academics to drive project outcomes. I will say also that in Australia, the term we often use for patients in public is consumers because they're healthcare consumers. So in case I say that word a few times, just as a muscle memory, you'll know what that is. My role at the moment has also now expanded into embedding equity considerations across the entire digital innovation pipeline, whether it's from initial problem identification all the way to implementation into routine clinical practice. So, Laura, are you able to jump in and talk a little bit about your background, or would you like me to do it? I appreciate if it's noisy for you in the background. Questionable. Okay, I'm happy to jump in and share a bit about Laura as well. So Dr. Laura Brown is the Manchester lead for our equity work. She's a senior lecturer in psychology, and her research interests focus on supporting diverse group of older people to live and age well. She's been focusing on the use of technology for aging and health related assessment, training, and engagement. And some of her populations of interest include long-term care residents and underrepresented ethnicities, and also older autistic adults. So with that, I think it's good time to dive right into the trilateral partnership, which is the International Collaborative for Translational Digital Health. And this actually is part of a broader MMT collaboration. So Melbourne, Manchester, and Toronto universities formed a trilateral alliance about 4 years ago in 2021. And the alliance aims to draw on joint expertise and resources to facilitate collaborations, whether it's for research or teaching or capacity building across our 3 universities. If anyone's interested, that's Barry from Melbourne. That's True Blue from Canada. And I'm sure you know this is Barnaby from Manchester. So I thought it's a nice way to sort of show the partnership. As I was saying, the ICTDH is a collaborative run by the 3 universities, and we have faculty level support and international relations office level support across the MMT partners. And we primarily exist to help seed and nurture international collaborations for digital health research and education. And we do that through a variety of things, whether it's collaborative research projects, exchange programs of students and staff. So I'm obviously on exchange at the moment. Sabine and Laura visited us earlier this year, and certainly also seminars like these and other workshops and symposia. And where possible, we also try and draw in industry partners as well. So the overall mission was to advance the field of digital health across our 3 countries to realize the development, implementation, and adoption of inclusive and equitable digital health technologies and digitally enabled care service models. So if anyone's wondering why these 3 countries specifically, or why these 3 universities, in some ways there are some similarities in our health systems through publicly funded programs, but also more generally culturally and things like that as well. So there is enough similarity there to be able to make some meaningful reciprocal exchanges. Now, within the broader trilateral, there are 4 hubs: digital health technologies, data science and AI, health services research and implementation, and digital health equity. So Laura Ibukun Enid, who's our other counterpart from Canada, and myself, we lead the digital health equity hub. Um, this is a new hub that wasn't there originally. Equity was more like a cross-cutting theme, but last year we sort of came together to create a standalone hub for digital health equity. And we've established a first of its kind international research and capacity building partnership because we think that this will be critical to centering equity and inclusion at the heart of digital health innovation globally, particularly as we are now seeing AI-powered solutions are gaining momentum as well around the world. So as I was saying, those are the 4 hub leads. We do have a lot of other contributors who make this possible. So obviously Sabine, we had Rebecca McPhillips, who was in Manchester until recently, Dr. Cara Browns and Carrie Van Rensburg from Melbourne as well. So it's very much takes a village sort of an effort. In terms of the hub's goals, so we look at equity in 2 different ways. We look at equity in outcomes, and Victoria in her presentation beautifully articulated some examples of unintended consequences that can occur from digital health projects. So certainly as a bare minimum, we want to look towards helping mitigate those unintended consequences. And I was talking to a mentor who once said, just because they are unintended doesn't mean you cannot anticipate them. So there is a lot of work that we can do in advance to sort of try and anticipate some of these unintended consequences and try and mitigate them upfront. On the flip side, aspirationally, we want to be a facilitator for narrowing the health divide across the population and using and leveraging technologies to help bridge whether it's access to care, quality of care, or safety of care related goals. But on the flip side, we also are really passionate about equity in process, because how we actually get to the digital health innovations is also very critical. And so I've got some examples here on the slide. This is certainly not like an exhaustive list, but as a bare minimum, incorporating lived experience expertise right from problem identification stages. One other thing we should also consider is, does this problem even need a digital solution? Because when we work in tech, often the default thinking could be, let's create a new fancy piece of technology to help solve this problem. But sometimes it's a systems issue, or sometimes it's a workforce resourcing issue. So we want to be thinking about, does this problem even need a digital solution? And thinking about meaningfully conducting co-design with diverse populations with consideration of power dynamics. Because you can do co-design in a way that can be harmful to people, or it can sort of erode trust in among the community members and so on. So how do we do co-design in a meaningful manner with consideration of power dynamics and transparency? And then this is something I'm personally passionate about, is having reflexivity about what outcomes do we measure when we evaluate our success. So this whole idea that what gets measured gets managed, and it's really helpful to think about, can we think laterally about what are some of the outcome measures that we are trying to assess as part of our BAU innovation evaluation programs. And so I've shared some lofty goals just then, but how do we actually operationalize them? So one way to do that we've thought about is a trilateral strategic intent as the vehicle for change to make this happen. And in some ways, our proposition is that by having the strategic intent in place, we want equity to be embedded as a part of our DNA across the 3 trilateral organizations. And equity is now a foundational principle rather than an afterthought that then we realize, I don't know, 2 years down the track, that we've harmed certain population groups through an innovation, for example. And so we really believe that international cross-border partnerships like ours, which are built on a shared mission and upfront consideration of equity, will help move the needle globally on equitable digital health innovations. And so we really aspire to be this force for good in terms of catalyzing inclusive and equitable innovation around the world. So if you're wondering what's a strategic intent, well, we kind of see it as an agreed set of equity-related principles, which will help guide the direction and conduct of digital health research, teaching, and capacity building among our 3 partner organizations. And certainly over time, we may open that up to other organizations. We certainly have collaborators around the world, including low middle income countries that we work with regularly. So this doesn't need to be in the long run, just be sort of closed off to the MMT. There's certainly opportunity to open that to more organizations. In terms of how we went about developing this, so it's very much a co-design process. We've provided opportunity to staff around the 3 universities at multiple times to sort of provide their input. So it all started with an initial landscape mapping survey last year, where we opened up sort of a bit of a survey to understand what people's expertise areas are, where they see the gaps and aspirations lie for digital health equity. What are some affiliated organizations that can help catalyze this shared mission, and so forth. So based on that landscape map, then we went into an online workshop. I've got a screenshot here. So we had great attendance from all 3 universities. This was held when I was visiting Manchester last year. And we got amazing rich data from the workshop, which we were then able to churn out into then creating a draft strategic intent. And that is now at open consultation stage, where so we'll do a little bit of that later this afternoon, but we also have a survey as well that's now open if anyone wants to provide feedback. Once that's done, we'll finalize and have a sign-off process across the 3 universities, and then there'll be dissemination through internal communications, academic output, and potentially media coverage for public engagement. And then that gets into creating actually context-specific action plans at the 3 sites as well. So here's a little bit of a list of the sorts of things that we cover in the strategic intent. So we thought the first thing to do is to create a shared definition of digital health equity, to really articulate our vision and mission. And then we sort of get into research methods, expertise, and culture, how we engage with patients and consumers, how do we go about building capacity, how do we collaborate with industry, and what do we demand of our senior leadership, as well as what sort of things we want to put in place for governance and accountability. So this is the shared definition of digital health equity. This is the first draft that we came up with. I'll just pause for a minute and let you eyeball the definition instead of me reading it out for you. So I'll just pause for a second and let you read that. Well, we'll circulate the slides as well, so you'll have another chance to look at it more closely. But we thought for the purposes of today, we'll just share some examples of each of these categories in the slides themselves. I won't have the exhaustive document, but when we do have the 30-minute discussion afterwards, if anyone stays for it, you'll have a chance at the start to read it cover to cover. So why don't I sort of talk through some examples for now? So the vision within the broader within the initiative is that we envisage that digital technologies, where appropriate, will be leveraged to bridge gaps in healthcare and in health and social care access, use, and quality. We consider that global digital health ecosystems will possess capacity and know-how to drive digital innovation equitably, and unintended consequences and inadvertent harm from inequitable solutions will be foreseen and mitigated, or if that's not done, at least retrospectively documented. So this we sort of see as our kind of North Star at the moment, and certainly this is a living document, so that might change. But really, to really make that vision achievable, then our mission is to advance research capacity, build capacity, and provide thought leadership to drive equitable digital health innovation, both at national and international levels. So that's sort of our broader vision and mission, but I guess I thought we could then give you some examples of things. And as I was saying, this is not an exhaustive list, but within the scope of research methods and expertise, we sort of think that we will encourage pluralism in research teams, including technical disciplines or research methods or socio-demographic characteristics. And we'll also help ensure that our digital researchers have the expertise to conduct their research with reflexivity and socio-cultural competence. Now, when we get to engaging with consumers and the public, we sort of say that we will build and maintain meaningful reciprocal relationships with priority communities and ensure appropriate stakeholder representation. So I'll also say that the word priority communities is a deliberate choice, because often we use terms which are more deficit based, for example, vulnerable groups or seldom heard groups. Priority communities is more a strengths based term that one of our colleagues at Melbourne who works with Indigenous communities really advocates for. And so it's almost like saying these are the communities that the health system needs to prioritize. So we've been quite intentional in the wording we've chosen as well. And another extension to that is we want to utilize strengths-based approaches that leverage the resources, resilience, and knowledge that are held within these communities as well. Because as I was saying before, often the default is when we think about marginalized groups, the default is to think about what's missing, and then it's a missed opportunity to leverage the strengths that they bring to the table. Moving on to capacity building, we talked about providing access to sort of our own staff and providing them foundational training and resources so they can embed equity in their own practice. So that's more inward looking, but more outward looking is we want to then also help advance formal offerings of formal and informal offerings of teaching and learning within sort of the broader community, both across our universities and beyond. And when it comes to industry collaboration, for example, we want to practice diligence with respect to ethical and equity ramifications of potential new industry partnerships and really thinking beyond the bottom line into sort of considering, do these industry partners also share our values and they exhibit those values in the way they operate in the world? When it comes to leadership, for example, we want to be thinking about how we can contribute constructively to debates on related issues where we are equipped to speak with authority as researchers. So one example could be fairness issues relating to health data collection by the government. And so, for example, then an extension of that is governance and accountability. And so an example would be that we want to help formulate and implement a minimum reporting standard for any outputs we develop. So whether it's project reports or academic papers, creating some minimum reporting standards so we can record proactively how equity issues were considered in a specific digital health project.